Going on the record at 9:38, this is the perpetuation deposition of Dr. Kim, taken on behalf of the plaintiff in the matter of Ray F. Castle, guardian ad litem of Sean Castle, an incapacitated adult plaintiff, versus Salem Hospital et al. Defendants. Filed in the Circuit Court of the State of Oregon for the County of Marion, case number 12C24245. The deposition is being held at 1011 Commercial Street Northeast, Salem, Oregon, on May 3rd, 2018. Will counsel please state their appearances for the record?
Brian Whitehead for the plaintiff.
Hillary Taylor on behalf of Dr. Johnson.
Jeff Young on behalf of Dr. Ishmael and Salem Pulmonary Associates.
The court reporter may now swear in the witness.
Could you raise your right hand, please? Do you swear or affirm that the testimony you're about to give in this cause will be the truth, the whole truth, and nothing but the truth?
Yes.
Could you please state your name?
Q Kim.
And what do you do for a living?
I'm a diagnostic radiologist, neuroradiologist. Neuroradiology is my specialty.
Okay. And where do you work?
I work for Salem Radiology Consultants. Work at multiple sites, mainly at our office in Salem Hospital and Salem Clinic.
Okay. And what is your education and experience in the area of radiology?
I did medical school at Wayne State University. I did an internship year in Virginia Mason in Seattle, Washington. Did a 4-year diagnostic radiology residency at University of Michigan, and then an additional year of fellowship training in neuroradiology at University of Michigan.
Okay. And when you say neuroradiology, is that a specialty?
It's a subspecialty of radiology.
Okay. So in your job as a neuroradiologist, what do you actually do?
I do imaging interpretations, diagnostic neuroradiology primarily, which is diagnosing, interpreting images primarily of the head, neck, brain, and spine.
Okay. So when you're looking at the imaging, what do you look for?
I look for neuro diseases.
Okay. Abnormalities?
Abnormalities, yes.
Okay. And you report on both abnormalities and normal findings, is that correct?
I may not specifically comment that all things are normal, but I have a checklist that I go through that I comment on.
Okay. And when you do that, is it important to be accurate?
Absolutely.
Why is that?
You're making diagnostic decisions that determine the course of treatments for a lot of people, diagnose diseases in a lot of people. So it's important to be accurate because a lot of my diagnosis will determine often if a person goes to surgery, what kind of treatment that they receive.
Okay.
And
so,
also, go ahead.
go ahead.
And to also explain a lot of their symptoms if possible.
All right. So basically, it's important that you're accurate because these are life and death situations, perhaps. Is that correct?
Possibly.
Okay. And do you oftentimes take a history of the presentation in the hospital?
I am always, in the requisition, a history is usually provided or at least requested.
Okay. And why is it important to have a history?
Because the context can determine imaging findings that may not necessarily be entirely specific, but it also kind of gives you the context of what you're looking at.
So does it help you focus on what you're looking for?
It can, but you look at the study globally, but it can help you.
Okay. And so it sounds to me like what you're trying to say is that you're objective when you look at the imaging. Is that correct?
Yes.
Leading.
Join.
Okay. Do you try to read what you see in the imaging without any preconceived notions of what is there?
I look at the images and make my decisions. A lot of times the history will be helpful.
Okay. Do you let the potential for litigation affect your reading of the images?
Objection or relevance.
Objection, leading, and relevance.
Go ahead and answer the question.
Can you repeat that question again?
Do you let the potential for litigation affect your reading of the imaging?
Same
Same
objection.
objection.
Am I to answer?
Yes.
I try to get everything right. I don't want to get sued if that's the question. So I do my best on every study to read it accurately.
Okay. Before I get into the details of this case, I want to clarify a few points about your involvement in this matter. First of all, you and I have never talked before, is that correct?
That is correct.
Okay, and we've never discussed this case, is that correct?
Correct.
And you were involved in the diagnosis of Sean Castle on 8/31 of 2001, is that correct?
Objection leading.
2011,
I read his CT and MRI,
okay,
and I believe a chest x-ray.
all right. So now, have you discussed this case before with any attorney representing any of the defendants in this matter? That would be Dr. Ismail, Dr. Johnson, or Salem Pulmonary Associates.
I have not.
Okay, and you do have your own attorney here, Mr. Polimo?
Mr. Polino is representing me, yes.
Yeah, okay. So you are neither a hired expert witness on behalf of Mr. Castle, Dr. Johnson, Dr. Ismail, or Salem Pulmonary Associates, is that correct?
Correct.
Now, getting into your involvement in Mr. Castle's case, I assume that what you did is try to perform the same function that you already said you try to perform on all imaging, and that is to find out what you saw in the imaging and report that accurately.
That is correct.
Okay? And you understood that that was critical importance to the care of Mr. Castle, is that correct?
I don't recall thinking about that with Mr. Castle specifically, but I tried to read every patient accurately.
Okay. Okay, I would like the witness to be handed Exhibit 1. Could you review that document?
Okay.
Okay, is that your report from the MRI that was undertaken at Salem Hospital on 8/31 of 2011?
I have a report of a CT in front of me.
Oh, that's what I meant, the CT. Yeah, I'm
yes,
sorry.
from the CT that I read.
Okay. And let's go to your clinical information that you put down on that report. It said 40-year-old male, status post-ground level fall. Why did you put that there?
Because that was the clinical history that I was provided by the ordering clinician.
Okay. And then in your impression, you put low attenuation involving the central aspect of the pons. This is primarily concerning for central pontine osmotic demyelation syndrome. And then you recommended an MRI for further study of the situation. Is that correct?
Correct.
Just for the jury, what is central pontine osmotic demyelation syndrome?
It's a disorder of demyelination, which is the white matter in the brain that can occur in this characteristic location of the brainstem, and the primary reported causes are from correction of hyponatremia or low sodium, although they do say that it can occur in people with normal electrolyte status as well.
Okay. Now, that was some pretty big language that a lot of people wouldn't understand. Can you maybe give that to us in a little more of a layman's term that the jury could understand?
Sure. It's basically injury to the brainstem in a characteristic location that occurs, and the primary evidence-based reported causes of it is when someone presents with an abnormally low sodium in the air electrolytes, and in the process of correcting that process, this is a classic result of injury to certain kinds of brain cells, which are called oligodendrocytes. And that injury causes this particular pattern to show up on the CT.
Okay. So, is there one of the images that you can show that pattern to the jury that you have in front of you?
Objection, relevance, foundation.
Join.
You can go ahead and answer the question. Off the record for a second.
Going off the record at 9:51.
Just for your information, when they object.
We're going back on the record at 9:58. You may proceed.
So, do you recall which, when you do imaging of a brain, do you take different slices when you do a CT scan?
There's multiple slices that we take, yes.
Okay. Do you recall how many slices you took in this study?
I don't recall looking at how many images are per study. Every patient is different because everybody's a different size, and we acquire them in 5mm sections for a CT. So depending on how big your head is, it can determine slight variances in the number of slices that are obtained.
Okay. And do you remember taking a slice that showed the low attenuation involving the central aspect of the pons in this case?
I'm a little confused because I don't really think about it in that capacity. I remember the anatomic location and looking at that particular area like I do on every CT of the brain.
Okay. So you do remember looking at that area?
Objection, foundation, relevance, leading.
Okay, go ahead and answer the question.
Yes, because this is an interesting case to a radiologist. So I do remember the case because it is one of these situations where I look at it and I can make an immediate diagnosis.
Okay, could you show us that slice?
Objection, relevance.
He said he remembered it.
No, I don't think he didn't say he remembered a specific image. Again, you can show him an image and ask him a question about it. But he's not going to search through the images.
I have the same objection.
Okay, and I'd like you to do it anyway.
Counsel, go off the record.
Going off the record at 10 a.m.
I would ask for a second.
We're going back on the record at 10:14.
Okay, we're back on the record. we're talking about your impression from reading the CT scan that there was low attenuation involving the central aspect of the pons. This is primarily concerning for central pontine osmotic demyelination syndrome. Do you remember which image demonstrates that?
I don't recall the specific image number. I mean, this is years ago. I know where in the anatomy of the brain I was looking.
Okay, and so you could easily turn to that in this group of images and show us that one. Is that correct?
Objection leading.
Same objection.
Do I answer?
The judge gets to rule whether that's leading or not.
Well, the question was so you could, and you just need to change the form of the question as you've asked it.
Can you identify which section of the imaging would identify the low attenuation involving the central aspect of the pons?
Objection, relevance, and foundation.
Same objection.
Overruled.
I can identify the pons quickly.
Okay, could you please do that for us?
Objection, relevance, foundation.
Same objection.
Overruled.
Scroll. Slower. Keep going. Keep going. Go back. One more. Nope, other way. Right there. Stop.
Okay. And which image is that for the record?
If you want me to answer?
Yes.
That is. Yeah, you guys have a little different setup than me here. Image number 10 of 32.
Okay. And could you point to the area of the pons that you found evidence of the demyelination syndrome for the jury? Okay. All right. Thank you. All right. Now I'm going to ask you about the what you did next after you saw that imaging you just demonstrated to us.
I see in my report that I recommended MRI.
Okay, and was an MRI undertaken on the same day?
Yes.
Okay. And could you explain to the jury what that is?
An MRI?
Yes.
It's a different form of imaging. It's magnetic resonance imaging. It's a
Okay.
different form of study.
All right. And do you you have in front of you Exhibit 2 yet, or has that been provided to you?
I have it now.
Okay. So, could you review that briefly,
Yes.
and then we'll go over your findings. Yeah, put the MRI.
Okay.
All right, now, you made some key findings in that on the second page, where you said there was marked signal abnormality with flare and T2 hypersensitivity, and
Intensity.
restricted diffusion corresponding to the central pons.
Objection leading.
Can you show us, do you remember that image on the MRI?
I don't recall the particular image number, but I said what sequence and where anatomically it should be.
Okay, could you identify that on the MRI?
Can you pull up the flare? Series number 9. It's the second one from the left. Correct? Just double click on it, should blow up.
Okay.
Keep going. It's there. Stop.
All right. And can you show us where that signal abnormality with the flare in T12 hypersensitivity was located?
Objection, relevance, calls for speculation, lack of foundation.
Same objection.
Overruled.
It's flare and T2 hyperintensity.
And is that it looks like almost a crown-shaped object in the middle of the...
It is the bright signal in the middle of the pons.
Okay. And what exactly does that show?
What does that show?
Yes.
The bright signal?
Yes.
It shows that there is edema in the brainstem.
Okay. And as a result of that signal, what diagnosis did you make?
Central pontine myelinolysis, or osmotic demyelination syndrome.
Okay. And did you also indicate anything in your report indicating the age of that demyelination?
I said in my report that I'm looking at here, I'm not looking at that sequence, but there was the presence of what we call restricted diffusion on a different sequence, and that suggests that this is indicative of a more acute etiology.
Okay. And those are big words again. So would you explain to the jury what acute etiology means?
Means relatively recent, not old.
Okay. And when you say relatively recent, not old, what do you mean by that? Give us a time frame.
Objection, calls for speculation.
Objection, relevance, foundation.
Your Honor?
The witness can testify, the objection of relevance is overruled and foundation is overruled. The doctor is testifying about his report results. The calls for speculation is a question that asks the doctor to identify if he knows, and if he doesn't know, then he would be speculating, and that's for him to say.
Okay. Can you answer the question?
When I'm saying acute in this case, we sometimes use a little bit of a broader spectrum. We can say acute or subacute. And if I'm indicating that, generally it depends on the sequence and the abnormality. By acute, I'm just saying relatively recent, so it could be anywhere from less than a day to several days old.
Okay. You also mentioned an underlying component of Wernicke's encephalopathy, right? What is that?
I said it's possible.
Okay.
A component is also possible, is what I said.
Okay. All right. So you didn't make that diagnosis. You just said that was a possible diagnosis.
I said that was also the presence of Wernicke's encephalopathy in this setting was also a possibility.
Okay. Now you also indicated that there was a flare in T2 hyperintensity corresponding to the bilateral basal ganglia and the thalamus. Thalamus, okay. What is that?
Those are additional structures within the brain.
Okay. Is that something that is commonly seen with osmotic demyelination syndrome?
It certainly can be.
Okay. And can you show us that on the imaging?
Objection, relevance.
Same objection.
Go back to the same sequence that we were on. Yes. Stop. So thalami, this spot symmetric, and this signal here. You can keep going. That's a thalami, or thalamus times 2. Basal ganglia, lentiform nucleus of the basal ganglia.
Okay. And you saw something abnormal in there?
This bright signal here, where it kind of makes this shape,
Okay.
symmetric on both sides, this outline and this outline, and this portion here and this portion here.
Okay. And what does that mean?
That also means that there's a process going on there.
Okay. So is that a part of the brain that was also affected by the demyelination syndrome?
I said it certainly could be part of the demyelination process.
Okay.
I mean, part of the osmotic demyelination syndrome. I want to be a little bit careful there because this is physiology or anatomy as well. These are technically neurons or brain cells, and when we're talking about demyelination, we're talking about white matter tracts going into the brainstem. But this is definitely described as part of the whole osmotic demyelination process. When they're involving these outside components of the pons, they call it extrapontine myelinolysis.
Okay. Thank you. That's all the questions I have.
Okay.
Please go off the record just
Let
for
the
a moment.
judge go.
Counsel, is there any need for the judge to stay on the phone at this time?
Not on my behalf, Your Honor.
No, I don't think so,
No,
Judge.
thank you, Your Honor.
Thank you.
Thank you, counsel.
So do you want to go off the record for a minute? No? All right. Dr. Kim, just a couple questions for you.
Okay.
So as I believe Mr. White had established, you're not here as an expert, correct? You haven't been retained by myself or Mr. Whitehead?
That is correct.
All right. And you haven't reviewed any of the records of Mr. Castle's hospitalization from August 19th through 23rd, 2011, is that correct? For your testimony today?
What I can recall, like I said, was when I was initially notified about this potential case years ago, I remember pulling up the study to refresh my memory on what it was. I cannot recall going into the chart notes. I don't even recall if we had electronic records then. But since then, I have not looked at the studies or chart records at all.
Okay. So none of your testimony today is informed by any knowledge that you could have had about Mr. Castle's previous care before August 31st, 2011. Is that correct?
I only have the histories that were provided to me. I can't recall. No, I discussed and the case with Dr. Norton. That's what I documented here on the MRI. And I don't recall the details of that case. I usually do that just to give information and if they have any questions.
Okay.
And sometimes they provide additional information to me, but I don't recall the details of that.
And the history you're referring to is the clinical information that's found on Exhibit 1 and Exhibit 2, which is the, on Exhibit 1, it's the clinical information we talked about, 40-year-old man, status post-ground level fall. Is that correct?
That is correct.
And then the history that you had that appears on the MRI on Exhibit 2 is the clinical information, 40-year-old man, Wernicke's encephalopathy. Patient has a history of alcohol abuse, currently on detoxification. Is that correct?
That is what I have in there.
Okay, I'm going to object to that and ask that it be stricken, and based upon relevancy grounds, prejudice versus probity type analysis, that it has no relevance, and if it is relevant, that its prejudice outweighs its probative value.
Great. That's all I have for you.
Okay.
Doctor, when you review the studies, as you've indicated to counsel for the plaintiff in response to his questions, it's important to be accurate, correct?
Yes.
Okay. And when you interpret imaging studies, it's important to consider all of the clinical information that's provided to you in the requisition form. Is that correct?
Yes.
Okay. And in response to counsel's questions about the MRI study, the clinical information also makes mention of a history of alcohol abuse, correct?
I have that history.
Okay.
I
And it
cannot
also-
recall.
Sorry to interrupt. Go ahead.
Okay. I cannot recall whether that was the typed requisition that the clinician did, or whether it was additional information provided upon talking to the clinicians.
And the other piece of clinical information that was provided to you is that this patient, Mr. Castle, was on detoxification, correct?
I put that in there, so I obtained that piece of information somehow.
Okay. Now, counsel focused your attention to the osmotic demyelination syndrome and the Wernicke's encephalopathy, but isn't it true that you also made other findings apart from that, outside of what counsel has focused your attention to?
Yes, I commented on additional findings in the brain.
Okay. Were there additional findings in the brain that you commented upon that would be pertinent with respect to the history of alcohol abuse?
I did think for a 40-year-old man, he had advanced generalized brain volume loss.
And in your experience, expertise, and training as a subspecialty neuroradiologist, low brain volume is common with chronic alcohol
may I
abuse,
interject for a
correct?
second? Just want to make a continuing objection to anything to do with alcohol consumption, and for the same reasons I previously stated. And then I'll just let you go ahead with your questioning if I can have a continuing objection.
You may, counsel. Thank you.
Thank you. Thank you.
Can you read back the question?
I didn't get a few of the middle words because he was objecting, so if
Okay.
you could restate.
And doctor, with respect to the low brain volume that you described, that's a common issue based on your education and experience and training with respect to patients who have chronic alcohol abuse, correct?
The finding itself is non-specific, but it can be seen in alcoholics. It's not the characteristic pattern. If I were to see disproportionate cerebellar atrophy, I could be more specific. But if you're asking me if a chronic alcoholic could have brain volume loss, yes, but there are innumerable potential causes of brain volume loss.
And doctor, did you see any other findings that would be related to the history that was provided to you of alcohol abuse?
Not beyond that, nothing specific.
Now, Mr. Castle at Salem Hospital also had some issues with his nutritional status. Were there any findings that you saw in the study that would relate to that?
For his nutritional status,
Correct.
well, it's healthy people don't, I can only infer what the primary cause of what this is osmotic demyelination is, which is relatively significant hyponatremia or low sodium, and healthy people don't walk around with extremely low sodium levels.
No further questions.
No, we're not. So I want to state for the record that I'm going to ask him some questions about the alcohol and how it relates to this case, only in the event, so that I have those questions, or I have that cross-examination on that issue on the record.
Yeah, you're not waiving your objection.
I'm not waiving
That's
my
fine.
objection. I'm not opening the door. Do you agree, counsel?
sure. I don't think you get to have it both ways. But.
I'm fine with that.
Okay. All right, so, so the alcohol, I understand the studies correlate alcohol consumption with acute demyelination syndrome. Is that correct?
Pardon me?
So is there a correlation between alcoholism and getting the central pontine demyelination syndrome?
You don't have to be an alcoholic to get central pontine myelinolysis.
So
or
is there,
demyelination.
is there a correlation between one and the other?
There could be.
Okay, and is that because when you're an alcoholic, you are more likely to present with low sodium?
You are, if you are a chronic long-term alcoholic, you are more likely to present with multiple deficiencies,
Okay,
not just sodium.
okay. So the causal relation, if any, of alcoholism to central pontine is that it depletes your sodium because you don't get enough nutrition, and then you would more likely to present to the hospital with the need for sodium replacement. Is that correct?
Objection, relevance, foundation, leading.
Same.
I don't know the answer to that.
Okay.
I know, you know, if you're talking, when I say Wernicke's, that's a little bit more specific. Because that's generally a thiamine and vitamin B related issue. I have to mention that in this case, like I do in a lot of cases, if I think it's on the radar, because you can presumptively treat that easily by administering thiamine and vitamin B. But if you don't, you can have adverse consequences. There are certain diseases that we have to treat presumptively until it's ruled out.
Okay, that's all the questions I have.
Nothing further.
Thank you.
Thank you.
This concludes the perpetuation deposition of Dr. Kim. We're going off the record at 10:36.